So thank you very much. Great talk, Cassie. Excellent. Let me now help you go from the past into the future. You just heard the past. So my disclosure is the same as before. So what do we know? Let me confirm that everything you've heard so far is correct. That historically, all carotid artery stenting to endarterectomy trials have shown the same thing, that there's a higher risk of stroke with carotid stenting as compared to carotid endarterectomy. This is multiple trials, all done with the same strategy, a stent, a distal filter, compared to endarterectomy. Regardless of what stent you use, regardless of what distal filter you use currently available, the outcomes are the same. The outcomes, though, are driven by one thing, and that's a high risk of minor stroke compared to carotid stenting. There's no difference in death, no difference in major stroke in every single randomized trial that's been done to date. It's minor stroke where you see the problem. And if you look at the composite endpoints, as you've already heard, this is CREST, but they all show the same thing. ACSU2, ACT1, CREST, all the same thing. Long term, there's no difference in composite endpoints. What you also know is that if you look at day 31 out to year 4 or year 5, the outcomes are the same as well. Again, every single randomized trial is the same thing. Day 31 out, it's all the same thing. It's all peri-procedural. Peri-procedural defined in this case as 30 days, but really we know it's at the time of the procedure. Look at freedom from TLR. It's exactly the same. Every trial shows the same thing, superimposed in terms of durability of stenting as compared to endarterectomy. You also see something very similar in every single randomized trial that's also consistent, which is that myocardial infarction has always been higher in every single randomized trial in carotid endarterectomy as compared to carotid artery stenting. You also see that cranial nerve palsy, whether you look at TCAR or carotid artery stenting transfemorally, is lower as compared to endarterectomy. And in some cases like this is in CREST, in 2.1% of patients, it was unresolved in 6 months. So does that count as a minor stroke? Even if it doesn't, just keep that in mind. There is a higher risk, and that's been shown in multiple VQI database evaluations as well. And for, again, site complications are higher with endarterectomy as compared to transfemoral stenting, and also compared to TCAR because you have a small incision with TCAR. So again, endarterectomy has all those negatives. So put it all together. In all randomized trials, more than 8,000 patients randomized across the board, the benefit and outcomes of endarterectomy to transfemoral carotid artery stenting is driven only by high risk of minor stroke in the peri-procedural period, 30 days, with carotid stenting. Death and major stroke are the same, high risk of MI with endarterectomy, high risk of cranial nerve palsy with endarterectomy, high risk of access site complications with endarterectomy, and that is compared to transfemoral and compared to TCAR. Okay? So the question is, why do we have this high risk of peri-procedural strokes? If we keep doing the same thing over and over and study a different type of distal EPD along with a stent and do another study, we're going to get the same outcomes. It's almost unethical to do the same thing again. We know what the outcomes are. 8,000 patients have told us that. Current distal embolic protection devices do not work. We also know that the vast majority of the risk of stroke occurs during the stenting procedure itself, not during access, not during the post-procedure. It's the placement of the stent, and especially post-dilation. With post-dilation, where the plaque is extruded through the stent struts, has been associated with an independent risk of stroke and death, the specific post-dilation procedure. We also know that 90% of all particles, I mentioned this earlier, 90% of all particles confirmed in multiple independent studies, 90% of particles released during carotid stenting are less than 100 microns. As I showed before, all distal filters right now have pore sizes more than 100 microns, and all of them could have the risk of a shape mismatch between the filter and the vessel, because not all vessels are shaped the same. You could have particles going down the gutter, you could have particles going through. Small particles getting through causing minor stroke, big particles are caught. That's why major stroke is not different. So the question is, if we improve procedural embolic protection, then will that eliminate the difference in stroke rates between endarterectomy and stenting? Because that really is the only difference. So let's look at that. Let's look at various ways that we know improve procedural embolic protection. We have proximal protection with MoMA, which is flow cessation. You have flow reversal, which is TCAR also with the Gore system, which is flow reversal, which is transfemoral. You have enhanced distal embolic protection. I'll show that in just a minute. And you have mesh-covered stents. All strategies to improve one thing, which is procedural embolic protection. So let's look at first at flow reversal with the Gore system, which is occluding the common carotid artery and reversing flow, or the MoMA, where you have flow cessation. When you look at multiple studies, one is shown over here, just changing that, and these are large system, 8 and 9 French, going through the aortic arch. You have a risk of stroking down below 1%, regardless of the type of stent you use. Open cell, closed cell, doesn't matter. Stent use doesn't matter. As long as you improve procedural embolic protection, event rates go way down. What about, this is a study from my colleague from his site. So if you look at endarterectomy, and if you look at carotid artery stenting with a distal embolic protection device versus carotid artery stenting transfemorally with flow reversal, you have the lowest risk of adverse events with carotid artery stenting transfemorally with flow reversal. Why? Because flow reversal is better embolic protection than a single distal filter of the type that's currently available. TCAR is the same thing. Why do we have benefit of TCAR? We have benefit of TCAR because you have better flow reversal. Some may say it's because of aortic arch manipulation and reduction of that. Well, if you look at that and you look at a study done and published by Nazi and colleagues, they found that if you do TCAR with directly accessing the common carotid artery, and you have dynamic flow reversal versus a distal filter used by TCAR, you have a much higher risk of a stroke with TCAR, with a distal filter, the aortic arch is not involved, than you do with dynamic flow reversal. Again, emphasizing what we already know. The distal filters that currently exist are not good enough. They're better than nothing, but they're not good enough. They're 30-year-old technology. So that's where we get into improving embolic protection. So if we wanted to do a transfemoral system, again, doing the same thing over and over does not make sense. So what we did over here is we added a 40-micron pore to this, and the outcomes of that with MRI, using this technology, integrated embolic protection with 40-micron pores, MRI done pre and post at 48 hours, showing a reduction in incidence of new lesions as compared to a single distal filter from 87% down to 21%, same level that you would see with TCAR or endarterectomy, and the volume, which is what the brain actually cares about, and Dr. Zhu's the data over the last 15 years cares about not just for acute stroke, but also for long-term cognitive decline, is critical. The mean lesion volume goes down dramatically as well. Why? Because you've improved procedural embolic protection, 30-day outcomes showing a 1.3% risk of stroke, with this high-risk patient population, symptomatic, asymptomatic, comparing if you look at endarterectomy arms of various older studies, Sapphire, ACST2, CREST, ACT1, all of which are some low risk, some high risk, and look at TCAR as well, lower transfemoral numbers in this pivotal study at 30 days. You saw this earlier. If you look at a different way of optimizing procedural embolic protection, you've got the mesh-covered stents. This is a C-Guardian study looking at the C-Guard stent, 30-day outcomes in terms of risk of stroke at 1%. Again, very low risk of stroke from a transfemoral approach. Put that together and look at the new technologies in terms of transfemoral stenting with a distal filter with the Performance 2 study and NeuroGuard, or with the mesh-covered stent on the right side. These new stent technologies, 1.8%, 2% risk of stroke out at 1 year. And if you look at the various stenting or endarterectomy arms of older studies, you see higher risk of stroke. And on the far right side, you see no major strokes at 1 year as well. So really good results. And if you combine the two, 615 patients, no contralateral strokes either, 0. Again, showing with proper patient selection, good technique, you avoid contralateral strokes, which is just a marker of arch-related issues. And other studies have shown, as I showed earlier, that the arch is actually not the reason TCAR has low results. It's better procedural embolic protection. Now look at TCAR. So my colleague already gave a really good summary of why TCAR is durable and here to stay. And if you look at this study, looking at a systematic meta-analysis, looking at mortality, stroke exactly the same between TCAR and endarterectomy. And again, this is retrospective analysis of the VQI registry. There are no prospective one-year data for TCAR available yet. Roadster 3 is pending. We eagerly await that. But given the data that we have, no different stroke or mortality, higher MI with endarterectomy, higher cranial nerve palsy with endarterectomy. In this other study, looking at 7 years of the Transcarotid Revascularization Surveillance Project, with endarterectomy, 122,000 patients, 1.3% risk of stroke. TCAR, 50,000 patients, 1.6% risk of stroke. Transfemoral stenting done via the transfemoral approach with a single distal filter, of course it's going to be higher. We know that. We don't need to prove that over and over. We know that embolic protection, the way it currently exists, is not good enough. And this is with TCAR still in its first initial generation. As I showed earlier, maybe adding additional protection to TCAR will make outcomes even better. Endarterectomy has been around for 70 years, first described in 1953, 1954. Transfemoral stenting, about 25, 30 years. TCAR, about 10 to 15 years. So experience with both these is still early. As evolution continues, as it did with endarterectomy, we're going to get better results. And here's, you see just in the last 2 to 3 decades, outcomes with transfemoral stenting have been improving, and further improvements will also be there. So in conclusion, the main benefit of endarterectomy over stenting is lower procedural minor stroke, Really important to keep that in mind. That's because of an inadequate distal embolic protection given first-generation EPDs. To improve procedural embolic protection, whether that's by TCAR or it's by flow reversal or flow cessation or better distal filters or mesh-covered stents, you find stroke rates with stenting, whether it's TCAR or endarterectomy, TCAR or transfemoral, which are comparable or lower than endarterectomy. MIs and cranial nerve policies have always been higher for endarterectomy as compared to stenting, whether it's TCAR or transfemoral. Patients prefer a less invasive approach. And for the reasons, the feature of carotid stenosis treatment lies in less invasive approaches like carotid artery stenting, whether it's by transfemoral or transcarotid approach. And endarterectomy, of course, will still be necessary, but for boundary conditions where you have severe concentric calcification, if you're not going to be using shockwave, certain anatomies and mobile thrombus, of course, to look at this in the right way, you need a randomized study where all three modalities are tested. Thank you.